My name is Beth Boudreau, and I want to welcome you to our program, to our webinar, Dynamic Navigation for Microsurgery and Everyday Practice, presented by Dr. Paula Vila. Our moderator is Dr. Silvia LaRosa, and Dr. LaRosa received her dental degree from CES University in Medellin, Colombia, and her postgraduate degree in periodontics from the University of Illinois in Chicago. She's a diplomat of the American Board of Periodontology, and she served as president of the Pierce County Dental Society from 2016 to 2017. Currently, she serves as a member of the board of the trustees for the Pierce County Dental Foundation. Silvia incorporated dynamic navigation into her practice in 2017. She's always striving to better serve her patients and improve clinical outcomes, and has been very instrumental as a beta tester, providing feedback to the Navident team to enhance the technology. She's a key opinion leader in the field of navigation and has lectured nationally and internationally on the subject. Dr. Silvia LaRosa is in private practice with Dr. Manuel LaRosa, both in Tacoma and Gig Harbor, Washington. Together, they combine and treat all aspects of periodontal, oral maxillofacial surgery, dental implants, pathology, and aesthetics, as well as all aspects of surgical dentistry and anesthesia. Dr. LaRosa, the screen is all yours. Thank you.
Thank you, Beth. It has been a pleasure for me to be part of this webinar series. I want to thank you and Navident and Clarinov as well for the invitation, as well as for organizing this series. For all of you who did not have the opportunity to participate on the previous live webinars, you can access the recordings through the company. And I want to remind everyone as well to write your questions on the chat box, and we will be happy to address those during the Q&A. So we are in here today for a treat, as Dr. Villa will be sharing with us her experience using dynamic navigation in endodontics and in endodontic microsurgery. We know that this is an application that was once emergent, and now it has become a clinical reality. So without further ado, it is my pleasure, my honor to introduce a good friend of mine, Dr. Villa. Dr. Villa received her Doctor of Dental Surgery degree in addition to her certificate in postgraduate endodontics from CES University in Medellin, Colombia. She is a founder of the Graduate Endodontic Program at the University of Antioquia in Medellin, Colombia, where she is currently an associate professor. Dr. Villa is the ex-president of the Colombian Endodontic Association. She is author and co-author of many scientific publications and lectures extensively internationally in endodontic microsurgery. Dr. Villa is in private practice, limited to endodontics and endodontic microsurgery. Dr. Villa, we're very excited to learn from you. The virtual stage is all yours.
Thank you very much, Silvia. The honor is mine. I want to thank Navident family and thank you because I really delighted to be here. This is a pleasure to me and it's an honor to be here in this series of webinars. As Silvia just mentioned, I am an endodontist from Colombia, and I've been using dynamic navigation during some months, and today I want to share with you my experience as endodontist using dynamic navigation. First of all, remember the American Association of Endodontics gave us this chart some years ago to identify the difficulty of our endodontic cases. And to summarize these charts, the most difficult cases are those in which we find full coverage restorations that doesn't reflect original anatomy, or significant deviation from normal tooth form, or those cases in which canal is not visible in the X-rays, or when we find previous access complication. And considering endodontic microsurgery as an endodontic treatment, I would add two cases to the list, and are those in which we find cortical bone intact during endodontic microsurgery, or when we find lesions near some critical anatomical structures. Most of the time, the problem is we are blind. We cannot see inside the teeth, we cannot see inside the jaws, inside the pacing structures, but what if we could use technology to see inside teeth, to see inside jaws, to see inside anatomical structures in real time? It would be great. Static navigation has been used to solve some of those problems. With static navigation, we can enrich narrow canals, and we can guide some critical endodontic microsurgeries to reach the apex, or to reach the apical area. But there are some advantages and disadvantages of this technique. It makes it easier to access narrow canals, allows location of surgical area. In that way, we can perform less invasive surgeries. It's easier to perform a cortical window technique, helps to preserve neighboring anatomical structures. But some disadvantages we can find in static navigation are the guide might not match. Irrigation is not possible with the use of this kind of guides. They are restrictive, and it could be good or bad. It depends on how we look at it. They are time consuming. You need time to design the guide and time to print the guide. If you have the printer in your office, okay, there is not much problem. But if not, for sure you will need some hours, even some days. The guide could be break apart, and interocclusal space is needed, especially when we are working on posterior teeth. Well, dynamic navigation seems to be the solution for these disadvantages. So we are going to review what is dynamic navigation, how does it work, and its usefulness in endodontics. I would call dynamic navigation a new generation of guided endodontics and guided endodontic microsurgery. If you want to learn a little more about this technology, you can search terms like computer-guided surgery or navigated surgery, because this is not new. For endo, is new, but it's been used for neurosurgery during years, and in dentistry it's been plenty used for implant placement. What we have with dynamic navigation is a real-time tracking of instrument movement over patient tissue. It is like a GPS. In a GPS you have the map. In the map you have the rods, and you can see in real time your movement around the map. In the dynamic navigation, you have the map, which is the CBCT of your patient, and you will see in real time the movement of the instruments over the map, over the patient CBCT. There are different tracking systems, the electromagnetic tracking system and the optical tracking system. The electromagnetic tracking system is used for neurosurgical instruments, and optical tracking system is the one we use with dynamic navigation in dentistry. They are composed by stereoscopic cameras, and of course we need light, so there is a light source at the bottom. We need to have the software, a computer with the Navident software. In that computer we need to upload the CBCT of our patients, and these cameras are going to see some optical sensors that we need to attach over the patient and over the instruments we are going to use. Let's see how it works step by step. First of all, we need to a good case selection. The best cases for dynamic navigation are the most difficult cases. I mean, narrow canals, full coverage restoration, difficult endodontic microsurgeries. Then we will need to obtain the CBCT of our patient, and after we are ready to plan the case. The planning of the case will depend on what I'm going to do, an endodontic access or an endodontic microsurgery. For an endodontic access, I will display a thin implant over the tooth image, and I will control on the 3 dimensions the position of that implant. This implant will be my virtual guide, and in the next step, I will follow this virtual guide until reach the canal, the root canal. If I want to plan an endodontic microsurgery, there are 2 different ways to perform the endodontic microsurgery. One of them is a freehand computer-guided endodontic microsurgery. You don't need a previous plan. You will do it with freehand, but the whole time you will monitor the instruments on the computer screen. You can use any kind of surgical instruments. You can use bars, surgical bars like round bars or Lindemann bars or Secria bars. You can use piezoelectric instruments, any kind of piezoelectric saw. And you can also use trephines to perform the apicoectomy and the osteotomy. Also, you can use a pre-planned guide in a similar way how we plan an implant placement, but we are going to display the implant image over the apical area of the tooth we are going to operate. What you see here in the red box is the virtual plan, and the trephine is moving through the plan. My goal is to hold the center of the target. In that way, I am performing the apicoectomy exactly in the location I previously planned with the virtual guide. About the trephine, we can use any kind of trephine. I mean, any millimeters diameter trephine. We can adjust on the Navident software how many millimeters trephine we are going to use. So there is no problem. We are going to have the real information. Then we will need to perform the trace registration with a tracer tool after attaching the optical sensor over the patient. With a tracer tool, I'm going to slip some teeth surfaces while the cameras are tracking the optical sensors and match the position of the patient over the CBCT. Then we are almost ready and it's time to navigate. Before, we need to calibrate the instruments we want to use. We can use with Navident any kind of handpiece. We can use high speed, low speed, or piezoelectric handpiece, which I think is a big advantage of Navident. After calibrate the handpiece and the boards, we are ready. I want to share some clinical cases. This one is the first case I want to share with you. It's a very special case for me because this was my very first time using Navident. The patient is also a dentist and she's a very good friend of mine. 2 years before, during the extraction of the first lower molar, a root tip got retained. And we followed the apical area of this root tip and we could saw a lesion was growing around it. So we need to remove the root tip. But look at the axial view of the CBCT. Here we have the root tip near the apex of the premolar and very close to the mental foramen. Also, the cortical bone was intact. So what we have here was a big, big challenge. I decided to perform the surgery with the aid of Navident. I performed a cortical window technique and I'll show you the surgery, the complete surgery. After attaching the optical sensor, here I'm doing the race registration. The exact location of the window is being planned in real time. So I can be sure when I reach the medullary bone, I only want to put the cortical bone. Well, after finishing the cortical window, I remove the cortical bone, and immediately I found the root tip. It took me less than 5 seconds to find and remove the root tip. The cortical bone was put back and finished. Was done. It was a very conservative surgery, and it was really fun. Dynamic navigation has been described for many clinical applications, like maxillofacial trauma, removal of foreign bodies, temporomandibular joint surgery. Cortical window technique has been already described with dynamic navigation, orthodontic surgery, dental implant placement. Dental implant placement is the most common case in which dynamic navigation is used. And recently, endodontic microsurgery, this article was recently published at the end of the last year by Dr. Gianluca Gambarini and his group in Italy. They performed an endodontic microsurgery of an upper lateral incisor. It's not a difficult surgery, but the surgeon was a non-experienced operator. So they conclude that the dynamic navigation system allowed a non-experienced operator to precisely perform a minimal invasive osteotomy and root end resection during endodontic surgery. So it seems to be a good tool for teaching. Let's talk a little about endodontic microsurgery. There are some critical steps. We always need a full thickness flap. Then we will need an osteotomy. Remember, the goal of endodontic microsurgery is to reach the apical area, to remove the lesion, and to cut 3 millimeters of the root end. And after that, to fill the canal. So I will need to perform an osteotomy, apicoectomy, lesion removal, apical cavity preparation, and apical cavity filling. During osteotomy, apicoectomy, and lesion removal, I found Navident could be very useful for us, especially in most difficult cases. When we have the cortical bone intact and a cortical thick, especially in the lower molars area, it's been suggested the cortical window technique, also called bone window or bone lead. This technique has been described many years ago, but has been gaining interest in endodontic microsurgery during last years. It minimizes buccal bone depression. optimizes the immediate structural reconstruction of the defect because the cortical window is removed and at the end will be put it back. It works as a barrier membrane with osteogenic potential while preventing the entry of non-osteogenic cells. The bone window serves as autologous graft, which is the gold standard when we are talking about grafting in endodontic microsurgery. After performing the osteotomy, we need to perform the apicoectomy. Most of the times, we will need to cut 3 millimeters of the root end in a bevel approaching 0 degrees, while providing sufficient space to perform the root end cavity preparation and root end fill. To control the bevel of the cut is not easy, especially in posterior teeth. If we perform a cortical window technique, the cortical window must be perfectly located in front of the target area, perfectly. And it must be, it could be done by freehand with the aid of static navigation or with the aid of dynamic navigation. With freehand, okay, we can control the location of the window with a good previous planification over the CBCT, but will be difficult to control the depth of cut. The bevel of the apicoectomy is difficult to control, and also the direction of cut. If we use static navigation, the location of the window is easier. Also, the depth of the cut could be controlled. It depends on the design of the guide, but the bevel of the apicoectomy and the direction of cut cannot be controlled with this kind of guides. But if we use dynamic navigation, we can control the location of the window, the depth of cut, the bevel of the apicoectomy, and the direction of cut, because we are controlling, we are monitoring in real time while we are doing the cut. Let's see some clinical cases. In this case, I used a cortical window technique with a freehand computer guide endodontic microsurgery. The patient was referred to me to treat the lower first molar, which had a previous endodontic treatment, but I found there was a separated instrument in the mesiolingual canal. Also, there was periapical lesion in distal and mesial root, and interradicular bond between mesial and distal root was intact. First, I performed the endodontic retreatment, but during the endodontic retreatment, I couldn't remove the separated instrument. To perform the endodontic microsurgery. In this particular case, I find very interesting the way how I could cut the apexes without touch the interradicular bone. Look how I can control the depth of cut, the bevel of the apicoectomy. At the end, I remove the cortical bone. The apexes are already cotton, so I only have to remove them. Here it is. The separated instrument was transapical. After that, we can perform the endodontic microsurgery, the next steps of endodontic microsurgery as usual. In this case, the patient was referred to perform the microsurgery of premolars. They were restored with full coverage restoration and post, and the lesion and apexes were very near mental foramen. There was less than 3 millimeters between the apexes and the mental foramen. Look at the axial view. You can control the apicoectomy, and you can control once you reach the lingual area of the roots and avoid cutting the lingual cortical bone. At the end, I remove the cortical bone. One of the apexes was attached. The other one was already cut. I think the combination between dynamic navigation and this technique, the cortical window technique, is a perfect combination because we can perform very conservative access to the apical area. At the end, the cortical bone is put back over some collagen. Another critical situation in endodontic microsurgery is when we find lesion near maxillary sinus. Most of the time, we are going to perform a freehand computer-guided endodontic microsurgery when we are in these areas. In this case, the patient was restored with temporary crowns and was referred to perform endodontic treatment of first molar. I found several problems in the mesial root. It seems to have a perforation in the furcal area and a second perforation in the apical area. Also, the apical zone of the root canal was not treated, and we found a big lesion near maxillary sinus. I decided microsurgery because I thought it was more predictable in this particular case. The cortical bone in this case was already perforated, but I could control the apicoectomy in 3 dimensions. And after removing the apex, I calibrate a cureta and I gently remove the lesion, avoiding go inside the maxillary sinus. Now then, you can calibrate any rigid instrument. So in this case, I decided to try with the cureta, and it was very successful. I could remove the whole lesion. Look at the sinus mucosa, how it moves while the patient is breathing. And look at the post-surgical. At the end of the surgery, I put an allograft, and here you can see the allograft that shows the lesion was completely removed without enter to the maxillary sinus. Only a little perforation was found here, but the mucosa is perfect. Also, we could obtain this beautiful histological result. I think this was a consequence of gently remove the lesion, the whole lesion. Another case in this special area, in this critical area near to maxillary sinus. This case was just published 2 days ago in Oral Health. The patient was referred to perform the endodontic microsurgery of second premolar. This tooth had 2 roots, as you can see here. The buccal root was healthy, there was no problem around the buccal tooth, but the palatal root has an apical lesion near maxillary sinus. So the big challenge in this case was to reach the apical area of the palatal root without enter to maxillary sinus. And as you can see here, we only had less than 1 millimeter of bone between the apical area of the tooth and the maxillary sinus. It was a big challenge. This surgery was performed with dynamic navigation, you will see.
Like a worn out recording of a favorite song. She lay there sleeping. In the personal columns. If you like me, come on. Get caught in. If you're not, oh God. If you have in the of the cake,
At the end, this is the cortical window designed according to the Navident. And we had a perfect access, enough access to manipulate the microsurgery instruments. Here you can see the micro mirror, and you can see the palatal root and the canal of the palatal root. Here the palatal and buccal root after filling. And this is the most beautiful slide of this case. The post-surgical CVCT of this patient, in which we can see the maxillary sinus was not perforated, and we created the enough space and little space to perform the whole procedure. We also can use trephines, as I mentioned before, and the trephines can be used while we are monitoring the path on the screen. As you can see in this case, I use a 5mm trephine to perform the apicoectomy and the osteotomy. Once I reach the palatal area of the root, I remove the trifine. Inside the trifine, I will find this block of bone with cortical bone, medullary bone, and the apex. I have to remove the apex from this bone. The bone is maintained in saline while I perform the rest of the surgery. And at the end of the surgery, the bone will be put back, and it will be the perfect autologous graft. The result, a very conservative microsurgery. Look, the amount of bone we lost after the surgery was minimal. As you can see here, we conserved the cortical bone, and for sure, the healing of this surgery is much better. Dynamic navigation has been also suggested for endodontics, for treating difficult cases like narrow canals, full coverage restoration, or some anatomical complexity. In this case, the patient was referred to treat this lower incisor. As you can see in the X-ray, the canal was only visible in the apical third. In the CBCT, we could see the canal visible in the apical and middle third, so we decided to perform the endodontic access with dynamic navigation. After isolation, I attached the optical sensor, plan the guide, the virtual guide, and then this is important because there is a little difference between static and dynamic navigation in this first step. We will have a freehand computer-guided access cavity from the beginning when we are using Navident. You can navigate from the first bar you are using. The first bar for sure is going to be a diamond bar, and after you reach dentin, you should use the correct bar. There are some kits I like, and I recommend this kit of SS White. This kit is designed for this kind of canals. We can find high speed and low speed bars with different lengths, and look at the tip, the diameter of the tips, the back diameter of the tips. Most of them are less than 1 millimeter. So I can perform an endodontic access, a very conservative endodontic access with this kind of bars. We can calibrate any of them. After control the position of the virtual guide, we need to hold the center of the target. And look how we can monitor in real time the movement of the bar inside the tooth. In 3 dimensions, which is very important. Once we reach the depth, I recommend to remove the smart layer, to use EDTA during 2 minutes, and after that, try to reach the canal. What we got in this case was a conservative access in the center of the crown and a perfect access to the apical third of the root. As you can see here, the preparation in the apical area of the access is less than 1 millimeter. In this case, the patient was referred to me to perform the endodontic treatment of this lateral incisor. As you can see here, the canal is visible only in the apical third. So after isolation and attaching the optical sensor, following the path of the virtual guide is really easy and fun. At the end, what we obtain is access to the apical third without deviation. As you can see here, the canal is prepared in the center of the root. And once the root canal is finished, the patient goes for the post. Another clinical situation, look, this is also a very narrow canal, but in this case, besides the narrow canal, we had an anatomical challenge because we found here a dense indenting. We decided to perform the access to the canal and to the dense indented using Navident. And this is the result. 2 little holes, one to the main canal and the other one to the dense indent. Full coverage restorations are a big challenge for us as endodontists, especially because sometimes the axis of the crown is not the same axis of the root, as in this case. We can have a lot of advantages using Navident in cases like this. Monitoring in a sagittal view, I think, is fantastic. You can control the bucolingual aspect of the core. And at the end, the root canals of those kind of teeth were very. In posterior teeth, we find an additional advantage. And is we don't need extra interocclusal space. We only need the space for our handpiece, our usual handpiece, and our usual bars. We can use the bars we always use for this kind of cases. In this case, I performed the access cavity of a lower molar, restored with a full coverage crown. About accuracy of dynamic navigation for endodontic access, there are little studies, and this is one of them. They wanted to analyze the accuracy of 2 computer-aided navigation techniques to guide the performance of endodontic access cavities compared with the conventional access procedure. So they use a lower incisor extracted by periodontal reasons, and they had 3 groups. In one group, they performed the endodontic access using Navident. In the other group, they use static navigation. And in the third group, they only planned the access over the CVCT, but the access were performed in the traditional way. Some results from this research. Look at this image. In yellow, you can find the planned access cavities, but in red, the access cavities performed. Look in the traditional way how they don't match. In this group, they found one perforation, and in 2 cases, they didn't find the canals. For static navigation, is much better, as you can see here in the axial view. But for dynamic navigation, it's almost perfect. The axes were almost perfectly located. Non-statistical differences between static and dynamic navigation were found, but dynamic navigation showed better results. About learning curve, trust me, is not a big learning curve using Naviden for endodontic. I want to show you this case. This case was performed by one of my students. I think this is not the most difficult case, but for a student, maybe it's a big challenge because the canal is narrow and is calcified in the coronal and cervical area. And this was the first time for her using Naviden. She planned the access, and after planning the access, she just followed the virtual guide. And after a few minutes, what she got was the access to the canal and a very conservative cavity. To finish, I want to mention some advantages and disadvantages of dynamic navigation. With dynamic navigation, we preserve the tactile perception, which I think is very important in all our procedures. It allows correction during surgery, even during endodontic access. We can control the direction, depth, and bevel of the apicoectomy, and we can make the irrigation in the way we need. Some disadvantages: the calibration errors might result in clinical mistakes. The learning curve, but I already mentioned about the learning curve, is not a big deal. There are not in vivo studies, but I think it's a matter of time. And I think the biggest disadvantage is the cost. So thank you very much for attending this lecture. If you have any question, maybe here, and I try to resolve your questions.
Paula, that was a fantastic presentation. It was structured, it was detailed. Your documentation is pristine. I totally commend you on it. There were certainly a few questions that were brought up in the chat box. I managed to answer a few, but I want you to elaborate in some others, okay? So I will read this to you in Spanish. I don't know if you can see the chat box or not. I will read it to you in Spanish and I will have to translate it in English as well. So, Dr. Villa, ¿usted fija los bloques de injerto autólogo o solo los vuelve a colocar? So let me say that. So basically they're asking if the autographs, if she fixates them back when she placed them, either with fixation, rigid fixation, or non-rigid fixation.
Okay, so I will answer in Spanish.
Okay.
Solo los vuelvo a colocar fijándolos muy bien, o con la ayuda de colágeno o con PRF, pero no uso tornillos de fijación.
So she puts the bone back. She uses the autograft. She does not use rigid fixation. She uses collagen and also sometimes PRF. All right. The next question, there was a question about calibration. I think I answered that myself about how to calibrate the instruments. Another question is, are you using a microscope with the Naviden system? Si estás usando el microscopio.
Yes. Well, during the time I'm using Naviden, I only can see one monitor. I mean, Naviden doesn't replace the microscope. They complement each other. But when you are navigating, when you are monitoring at the Naviden screen, you can watch through the microscope.
Understood. So tied to that, and I'd like to ask you a question, around that. So my question is more about the advantage of using navigation to create the axis in endo over the microscope. So, you know, is it more advantageous to do it with navigation, the axis? Do you find it, you know, that you're going to have a, you know, with a real-time visualization of your, you know, your path and your plan? Is that more advantageous over the microscope or the same?
Different, but I think it's easier with that with Navident. At the first step, when you reach the canal, is easier with Navident. After you reach the depth, you will need the microscope. You will need to see inside the canal. We need to see the changes of the dentin. We need to see the colors, but from the enamel to the depth, I think Navident is easier than only microscope. We can control the bucolingual aspect, what I found is very, very important. And we can control in real time in 3 dimensions.
Absolutely. Yeah, and you know, and you're right. I mean, we were talking about earlier about, again, the real time, not only visualization, but verification of the plan and the trajectory for you, I mean, as an endodontist, which is really neat with navigation.
Yes.
Something that you cannot really have with a study guide, for example. And, you know, you use, you know, you do a lot of endodontic microsurgery, you lecture internationally on it. And one of the things that I have been asked by even my colleagues here in endo is the use of the study guide. You know, do you find it more, you know, beneficial to use navigation over a study guide?
Absolutely.
When doing microsurgery?
Yes, absolutely. Absolutely. Because of the disadvantages I mentioned before, I mentioned at the first part of the lecture, I think with dynamic navigation, we solve the whole disadvantages of static navigation.
Correct, correct. And I think you mentioned one that is really critical, and it's true for me, and I don't do endo, as you know, but for implants included. You know, the turnaround time, the fabrication, I think the immediacy of using navigation, especially in endo, you have a case that is acute and you don't have to submit the plan to create a CAD/CAM fabricated study guide, but you can do it on site if you're dealing with an emergency. You can take your CBCT, you can plan it on the spot, you can treat it on the spot without any turnaround time. That is actually a great service to the patient.
Yes, time is money for the patient and for us.
Especially now we have to be more efficient with, you know, with the care that we provide to the patients, right? So, all right, so there was another question in Spanish. I will translate it as well. Let me start with Spanish. Alejandro Contreras pregunta, ¿cuáles son los parámetros que cambias en el Navident si vas a utilizar el piezo? El ajuste de parámetros es distinto al que utilizamos para colocar implantes. So let me just rephrase that. So what are the, what do you change in the parameters with Navident or with navigation when you're using a piezo instrument? The adjustment of the parameters is different than that we use when we're placing implants.
When I use the piezoelectric saws, I only need to choose the correct saw from the library. And most of the times I will perform a freehand surgery. I think the only change, the only important change is that I won't choose an implant, but I will choose a saw from the library.
Right. And I think I did reply to his question in brief, just kind of to get ahead of the question. The one thing and I think what he's trying to refer to is, as far as the parameters, is how to calibrate it. So the calibrator has a slot that is specific for the piezo.
Oh,
so
okay.
you have, you know, you can calibrate the axis to the high speed, to the low speed, and you can calibrate the tips of a high speed, a low speed, or a piezo. So there is a slot specific for the calibration of the piezo. Let's see, there was another one. No, I think that was it. I think we talked about the microscope. Let's see, because, oh, there is another question. I apologize, one more. Because it is an electronic device, there is or are any kind of physiological contraindication. I mean, patient with special conditions like a pacemaker. So, que si hay algún problema con personas que tienen, por ejemplo, un marcapaso.
For using Navident?
Yeah.
No?
No.
No? Absolutely no. It's not an electronic device over the patient.
Right. All right. Another clinical question for you, Nendo. It says, ¿ha tenido alguna complicación con la cicatrización del bloque? ¿Tiene alguna tomografía para ver cómo cicatriza? Me encantan sus casos. So basically, they're asking if there's any complications with the healing of the autogenous block graft or the repositioning of the block. And if they're asking if she has any scan to see how the healing is completed.
No he tenido ninguna complicación y es una técnica que uso mucho. Nunca he tenido una necrosis de la ventana cortical. Recientemente en el Journal of Endodontics de la última edición del mes pasado fue publicado un artículo que muestra el tipo de cicatrización que se obtiene. Es bueno de pronto que lo revises, la persona que me hizo la pregunta, donde muestra los controles con CBCT del tipo de cicatrización que obtenemos. En este momento estamos preparando precisamente un artículo con este tema, con navegación dinámica y combinación con la ventana cortical, donde les vamos a mostrar cómo ha sido la cicatrización de estos casos. Espero que salga a la luz pronto.
Perfecto. Okay. Otra pregunta. Can I have any sort of ultrasound tip calibrated? Las puntas de la punta de un
De ultrasonido.
¿Se pueden calibrar?
Yes, most of them. But the tips for root end preparation, I haven't calibrated them, never. I never haven't calibrated.
Yeah. And I think, again, you can calibrate any handpiece and you can calibrate truly any tip. So, I mean, I will delegate that to you as an endodontist. How thin are those tips, the ultrasound tips?
It depends.
Okay. So, I mean, if it appears like a drill.
1, 2 millimeters, it depends. There are a lot of kind of these tips.
I think that to answer that, I mean, if it's the similar diameter of a high-speed handpiece tip, then absolutely it can be calibrated.
What we have to highlight is we can calibrate any rigid instrument.
Correct.
That's it.
That is, yes. Perfect. Let's see. En caso de raíces con curvaturas, ¿es posible utilizar este sistema? So in case of roots with divergence, is it possible to use this system?
Más allá de la curvatura, no, porque un instrumento rígido no va a pasar más allá de la curvatura. Necesitamos un instrumento flexible para que entre más allá de la curvatura. Ahí ya se pierde la posibilidad de hacerlo. Por ahora, esperemos a futuro qué pasa.
Sí, y una cosa para añadir a eso es con el sistema, y lo voy a tener que hablar también en inglés, pero con el sistema tú puedes colocar un implante, o no un implante, básicamente el diseño, pues el TEP, en el sistema de navegación en un ángulo y luego colocar otro que intersecta. Yo no hago endodoncia, por supuesto, pero si tuvieras que tomar varios ángulos en algún acceso a nivel de hueso, tú puedes poner varios diferentes ángulos, empezar con el primero, seguir con el segundo, la segunda trayectoria y terminar el caso. Pero eso obviamente no se puede en endodoncia porque se necesitan...
En endodoncia eso implicaría un desgaste muy grande de dentina con seguridad.
Correcto. So basically, they were asking if it can be used in curved roots or divergent roots, and the answer is no. It's not because of the navigational system. It is because of the endodontic principles. You have to use flexible instruments to access into the canals. Is that correct? Right? Mm-hmm. Okay. I'm trying to learn some endo. Okay. Okay. Can I use any kind of laser to do the osteotomy? Que si pueden utilizar un láser para hacer la osteotomía. Eso ya no es con navegación, ya es básicamente no asociado con la navegación. So,
I don't use laser. I can't talk about laser because I don't have any experience cutting bone with laser.
Got it. All right. Cuando ajusto diferentes instrumentos rígidos, ¿debo hacer la calibración al momento de cambiarlos? ¿O puedo precalibrar y durante el procedimiento especificar en el sistema qué instrumento estoy usando o debe ser en vivo?
Cada vez que se cambia un instrumento debe ser calibrado.
Correcto.
Me explico, uso una fresa redonda y enseguida voy a usar una fresa de Lindemann, por ejemplo. Una vez cambio de la fresa redonda a la fresa de Lindemann, esta tendrá que ser calibrada. Es más, si cambio de una fresa redonda a otra fresa redonda, la nueva fresa que posicioné debe ser calibrada, porque puede haber pequeñas diferencias en la posición de la fresa que van a significar una diferencia clínica en el momento de operar.
Correcto, correcto. Tengo que traducir esta vaina. Okay, so the question was based on, do we need to calibrate every tip or every drill? So yes, it is best to calibrate every drill that you will use. So when you change your drills, if you're going from, let's say, a high-speed handpiece with any tips, you want to calibrate each of them. And then once you're doing in endo, using Lindemann burrs or again Brown burrs, you want to calibrate each of them. That it actually assures the accuracy and the safety of the procedure. All right. Are there any studies evaluating the difference in surgical outcomes with and without navigated surgery?
No yet.
Why use it in anterior or premolars when access is not an issue? ¿Entendiste esa pregunta? Sí, hay algunos estudios que básicamente muestran la diferencia entre los, básicamente, ¿cómo se dice? Quirúrgico con y sin la navegación.
No yet, but I think it's a matter of time.
Okay. ¿Y por qué usarlo en dientes anteriores o premolares cuando el acceso no es un problema? That was from Dr. Mohamed Fayad, who I know very well. Hi, Mo.
Gorgeous.
Just because it's easier.
Yeah.
It is easier. It is certainly more. It's actually what I am not an endodontist, but I will tell you from my perspective, it is more accurate. So you're going to be more conservative on your approach. I know that you all use microscopes in endo and you're very, very accurate in your accesses, and mostly of you are very conservative. But if you exactly know the trajectory and the path, you're going to minimize the destruction, the removal of dentin and enamel when you're having a more minimalistic access that is fully guided and is actually in real time. Something that with the study guides you don't have real time visualization of that trajectory.
I understand for a clinician with some experience, there is no difficult to perform an endodontic surgery in the anterior area, but if we can do it, why not? It's easier.
I have to ask a question to Beth. I have more questions in the chat box and I need to ask them. We have time, so it's all up to you.
Time, and apparently we still have, most of the attendees are still engaged, so, go right ahead.
So, can we continue with the question?
Yeah, we have time. Everybody would be great.
Perfect. All right, so hay un tipo de memoria en el sistema que me permita configurarlo al inicio y solo en el procedimiento activarlo. So,
hacer la planificación, sí, se puede hacer y siempre va a quedar grabada en el sistema tu planificación. La puedes hacer antes del procedimiento, un día antes, 2 días antes, cuando quieras. Y cuando ingreses al sistema vas a tener la planificación que hiciste sin ningún problema.
Correcto. Yeah, so basically, to answer to that, what she's answering is you can plan the case ahead of time. We all do. You can do it on the spot as well, but you don't have to do it on the spot. You can plan your cases ahead of schedule. You can, by the way, the software allows you to not only save different treatment plans on the same patient, but it allows you to take snapshots during the procedure and of your planning. And it provides recordings even of your planning and even during surgery. You can disable or enable that usability, that utility, and it's been great for us. Actually, a way to document, like Dr. Vidya is doing, is through the recordings, through the camera, through the micro tracker camera. All right. Okay, there's a financial question that I think we will allow the Navident team to answer about the cost of the system. Thank you, Daryl, for answering that. Let's see. All right, I think, let's see. No, that's it. Do you watch the color? What? Do you match the color of the shirt? Yes, we did. That is an excellent comment. No, we didn't. No, we're all dressed in the same color. Yes, we are.
So it wasn't intended, it was subliminal.
Totally subliminal.
It was part of the planification.
Absolutely. I think we answered all the questions, unless anybody wants last minute to, yes, I do have Instagram, somebody's asking me. So if anybody wants to has any additional questions, I know that you can forward them to Beth Boudreau. Beth, I'm sure that you will be receiving tons of questions. Please do so. We encourage you to continue learning about this technology. It is fascinating. As Beth mentioned, I have personally been using it for 3 years, and I cannot go back. I have not used a study guide in 3 years. And it's just the technology continues expanding the applications every day. So it's very exciting. I hope that you'll get the feel of this. And in endodontics, I think is a great tool as of what I see. Mm-hmm. So thank you so much for everybody's participation. Before I turn it over to Beth, I do want to remind everyone of the upcoming webinars. We have Dr. Joy Chen in a week, I believe, talking about all of that. And Dr. Luigi Stefanelli will be talking about navigation for the placement of pterygoid implants. So Beth, thank you. Thank you, everyone, and stay safe.
Thank you so much, Dr. LaRosa and Dr. Villa. That was really wonderful. Enjoyed it very much. And for all of you that attended, in probably about 24 hours or so, you're going to get an email to the email that you registered with. And in that email, you'll have a link to your CE documents. You'll have a link to the previous webinars in this series, to the recordings. You'll also have a recording copy of this webinar, and then the links to register for the last 2 in the series. And if you have any questions, I'm Beth at clarinav.com, and I can always forward whatever you need to know to the appropriate person. So thank you, everyone. Be healthy, be safe. Good night.
Thank you very much. Bye-bye.
Fantastic.